Oh yeah,
Right.
Should I stop? Should I stop? I stop sharing my screen so you can see each other.
100%. Thank you. So welcome, everybody. It's wonderful to have so many of you here already after all the public holidays we've had. And it's a special day with a special guest from the Netherlands that we have with us. And I'll introduce him in a minute, but I just want to start with a special welcome to all of you who are with us for the first time and just explain how this meeting works. So every Monday afternoon, we do a deep dive into hematology, and that is usually a combination of both clinical and laboratory hematology. And the aim is primarily towards giving our trainees very high level input, and also to share what we do around the country and in different units and see if we can align our practices and learn from each other. And so far, this has been a very, very successful venture, thanks to everybody really contributing and taking part so actively. So thank you for that. The way the meeting is structured is that today is going to be a little bit different than usual. Usually we have 3 speakers with some case presentations included. Today, we're going to have only 1 invited speaker, so there's going to be more than enough time for discussion. You're very welcome in the course of the talk to put your questions or comments in the chat box, but there will certainly be opportunity to speak out and verbally give your questions at the end. This session is also CPD accredited. So around the top of the hour, we will put a link in the chat box on which you can click and register for this meeting. We do not send CPD certificates anymore. These things are going straight to the HPCSA and captured on your registration number as CPD completed. So that's a new system that's different. We also record these sessions and they are hosted online if you want to come back and have a look at them later at the University of Cape Town Vula site. We will put the details of our secretary in the chat box as well, that if you don't have access yet, that you can find out how to get that. Great. So with that, behind me, it gives me great pleasure to welcome our international expert today, kindly sponsored by Janssen Pharmaceuticals, Professor Arnon Kater. And Professor Kater will speak to us on chronic lymphocytic leukemia, treatment approaches to CLL with high-risk molecular features. And Professor Kater is a professor of translational hematology at the University of Amsterdam. And his fundamental translational and clinical research is focused on lymphoma, in particular CLL. And he's also one of the founders of the Lymphoma and Myeloma Center in Amsterdam, LymCare. And yeah, if you look at the CV in the invitations you have received, you see that his base specialty is that of a physician, and hematology, and he's got a PhD in cell death regulation in CLL already far back in 2006, and he's done a postdoc at the Moores Cancer Center in San Diego and co-authored or authored more than 100 manuscripts and cited multiple thousands of times. Professor Kater, welcome to South Africa, at least virtually, and we look forward to your talk. The session and the screen is all yours.
Yeah, thank you very much. Thank you for the kind words and the invitation, and happy to see so many people back from your bank holidays. That's great that you are all here. And since actually I'm a colleague of you, and I think it should be the best thing of this kind of academic presentations is if there is a lot of interaction. So please interrupt me. You can either ask questions in the end, but you can also just raise your hand. I hope I will see it, and otherwise just shout something, and then we can have a lively discussion. Let me share my screen first. I think I share now, right? Do you see my screen?
No, we only see your face and video.
Oh, that's not so good. Okay, wait. Do it again. Share. No, that's the wrong one. Wait a minute. Just begin. Yes, share. Now you do see my screen, right? But you don't see the presentation. So I will add. No, I'll do something wrong here. Let me try again. But then
That looks good. Just put on the presentation part.
yeah, but no, you just need to go to the presentation. 1 second. Yes.
Perfect.
But you have the whole screen now, or only the?
It's actually in presentation mode now. I guess you want to show us the other screen.
Exactly. But I don't know why that's not working. I try one more time. Wait. Okay. Yes, and now I do the screen share.
Perfect.
Now you have the whole screen?
Yep, that looks good.
Sure. Okay, the whole screen, right? Yeah. Okay. So now you get the next. Now you get the next one, right? Completely.
Yes, that's right.
Okay, good. All right. So thanks again. I'm hopefully the next 40-45 minutes I will talk about sequencing treatments in the era of novel agents. Specifically in CLL, many things are changing, but also happen to change over the last 5 years. That's also why it's a very interesting field to be active in, because there are so many new developments, mostly actually based on molecular and cellular understandings of the disease. These are my disclosures. And for the research part, I get funded by the ERC Consolidator grant and also by a Dutch government VD grant. So there are actually currently 2 different kinds of treatment models in CLL. One is a continuous treatment, where you actually keep the patients on a drug to continuously debulk the patients. And we have done doing this for years, specifically in the elderly group of patients with chlorambucil for long durations. But we're also able to give this kind of continuous treatment now with venetoclax, single agent, with a BTK inhibitor, we have now a handful of, and with a PI3K inhibitor like adalasib. And the advantage of giving a long-term the drug and you only stop at the moment of progression is, of course, you have long-term tumor control. You even might argue that you have kind of a psychological control. But the disadvantage is that those treatments so far do not have a curative intention. You do have long-term side effects, and although we knew that was present, it became even more evident during the corona epidemic, where many groups, including ours, but mostly the Israeli group, have seen severe immunological defects also on vaccinations in patients that are taking a BTK inhibitor or venetoclax. And one thing you know for sure is if you keep on treating patients with a drug that do not cure, is that you will get development of resistance at a certain moment. And specifically in a country like the Netherlands, but also in South Africa, costs are an important aspect, and giving long life, let's say 5 years of continuous treatment, is going to be extremely expensive. So the other idea what you can do is that you debulk patients and you stop at a certain endpoint. And one of those endpoints, at least in studies, have been measuring MRD, minimal residual disease, by either flow cytometry or NGS or ASO-PCR, and see if you can reach a certain point that you can safely stop. And well, we know that we can get patients into an MRD negative state in at least a good number of patients with chemoimmunotherapy, with venetoclax plus an antibody, or obinutuzumab or rituximab, and I will show you that later, the newest data on venetoclax and BTK inhibition. And then you have 2 options. Currently, we don't have many things else we can do, but just watch and wait and wait until the disease comes back. And hopefully, but it is more future studies that we hope to start soon here, is that you can go for this very deep remission, almost similar to an AML or an ALL, is that you go for a minimal amount of cells, and then you can try to get a complete clone eradication by T-cell therapies like CAR therapy, what I will talk about in the end of my talk, bispecific antibodies, or good old allo stem cell transplants. And an advantage is you can just start and stop at a certain moment after 12 cycles or 15 cycles or 24, whatever the protocol says, is it's a one-size-fits-all protocol. An other advantage is you have extended drug-free periods, which benefits the patients, particularly the quality of life, and you have a shorter exposure of side effects, and perhaps, but that's a promise for the future, eradication is possible. The disadvantage of just giving 12 or 24 or 15 cycles is that you hope to get this MRD negative state, because we think that's prognostic important, but it's not really based on biological behavior. And next set of trials, what we're also doing, and I will discuss in a minute, is that you don't treat for a certain period, but you treat until you reach a certain biological readout, for instance, an MRD negative state. Another problem, what I will discuss this in this talk also, is that with this fixed duration treatments, is that we are still a bit uncertain how to rescue those patients if the disease comes back after a certain period of treatment-free holiday. So to give you some examples of the first approach, giving continuous treatment, I think you've all seen this data many times, specifically when you're more in the CLL field. The RESONATE-2 study was the large study where ibrutinib at a continuous basis was compared with 6 cycles of chlorambucil. And there we have seen that there is a difference in progression-free survival, at least, and so far not in overall survival. But one of the arguments here is that maybe you don't see a difference in overall survival because you give ibrutinib, or most of those patients could be treated with chlorambucil in the relapse setting. But at least you see that continuous ibrutinib for PFS for surely is outperforming chlorambucil for 6 months. You do have a price for this, as I just discussed. And well, some of those side effects are cumbersome, but as hematologists, we are used to even worse side effects, of course. But some are something to realize. First of all, hypertension, which is a class-specific treatment effect. Maybe ibrutinib a bit more than the others, but there is for sure a class effect here, which you should monitor and you should treat patients, specifically because you see an increased incidence of cardiac problems. Atrial fibrillation has been discussed many times for BTK inhibitors. Major hemorrhage, although that is not that much of a problem, but it still occurs. But the largest problem, I think, is that you have a certain group of patients that will get not only atrial fibrillation, but also ventricular tachycardias and even ventricular fibrillation and die from cardiac death. And although we don't know exactly which patients that are, it seems, if you look to the data from a bit eyeballing, that patients with heart diseases, which is more the elderly population that has CLL, is suffering more from these cardiac problems than other patients. So if you want to think a bit how we can work with those drugs and how you could even combine those drugs and how you could go for a biological-based treatment combination to stop treatment early, is to look a bit at the biology of those drugs. And the reason that a BTK inhibitor works is not so much killing of the cells, but it's specifically that you inhibit migration and adhesion to the lymph node microenvironment. And years earlier, it has been shown that there is a very important role for BTK in both B-cell receptor, but also integrin-mediated adhesion and homing. And so what you do if you give this kind of drugs like ibrutinib is that you actually stop the pit lane of the disease. So if you make a model, you can say that CLL cell is a disease, but I'll show you that later, where the cells are actually reborn or rejuvenated in the lymph node environment where they circle back and forth to. And if you stop this pit lane, like you could have seen yesterday in the Formula One, then it quickly, the cell gets weaker and weaker and will finally die off after a long period of time. So that's the prime role of ibrutinib. And indeed, if you look to the first trial that has been formed with ibrutinib, published by John Burt in JCO 2011, you can indeed see that this lymph nodes idea with a lot of groups, including ours, had already by in vitro data, but actually confirmed in vivo here. In the study, because of scariness or afraidness for side effects, ibrutinib was given in the phase 1 4 weeks on and 1 week off. And what you could see there is that as long as you gave ibrutinib in the beginning, your lymphocyte numbers increases, and in the stopping week it went down again. And well, of course, now we know that it actually is because of an active emigration from the lymph nodes to the peripheral blood, and a difficulty of the cells to go back into the lymph nodes. And if you look to the red line, that resulted in a very fast reduction of lymph node sizes. So if you think again about a pit lane and a racing car, we know that as long as there is one car in the circuit and you open the pit lane again, then you actually start the whole cycle up again. So this is the main reason that if you give a BTK inhibitor, which is a very good drug, but you have to give it continuously. So if you look again to those to my metaphor of the lymph node environment, which act as a pit lane, what we actually think of CLL is that CLL cells are like a racing car, pretty weak when they're in the peripheral blood. They can be maintained in the peripheral blood for maybe a couple of cycles, but at a certain moment they will die off. They have this small package of BCL2 that keeps them alive, but that is not enough over the long term. So what happens? The cells actually by CXCR4 signaling for and CXCR12 cells are bound are go into this lymph node, and in this lymph node they interact very actively with this natural microenvironment of those lymph nodes, and therefore by active signaling, by NF-kappa B activation, by mTOR activation, you get not only BCL2 but also other anti-apoptotic molecules like MCL1 and BCLXL, and their cells, when the cells leave the lymph node again, they are kind of rejuvenated and can survive again for a period of time. What we also have learned is that venetoclax is very active in the blood. I come to that in a minute, but less in the lymph node. And the very reason is that indeed venetoclax is a specific inhibitor of BCL2, and as we learn also from this slide is BCL2 is high in blood and lymph nodes, but specifically in the lymph node, you have this increased expression of other anti-apoptotic molecules, MCL1, BCLXL, and also BFL1, which makes the cells much less sensitive. And as I already told you earlier, is that ibrutinib is very active in the lymph node by chasing the cells out of it, but is less active in the other compartments. So if you look to ibrutinib maintenance to a combination that are a fixed dose. One of the most prime example, I think, is the study from the German CLL study group from Kirsten Fischer, published in the New England in 2019, where venetoclax was given for 12 cycles and was combined for the first six cycles with obinutuzumab, and the comparison arm, the standard arm was chlorambucil and obinutuzumab. And I think the nice thing what the German did, and the company before actually didn't do that, is that the duration of treatment was equal. So both treatment arms were for 1 year of defined treatment duration. And what you have seen there is that progression-free survival, pretty similar to the ibrutinib data I showed you earlier, outperformed the chemotherapy. But if you look to overall survival, at this moment yet, there is no clear difference in overall survival. Again, this can be due to the fact that patients in these studies had excellent access to BTK inhibitors in second line. So one of those reasons that venetoclax is working, but also you see relapses there, is that, as I just already alluded to earlier a bit, is that the activity is different per compartment. And that's actually what you can also see from their phase 1 trial. So if you look to their phase 1/2 trial, which I show you here, is published in the New England by Andrew Roberts a few years ago, what you can see is patients with a complete response do actually better than patients with a partial response. But if you look to the waterfall plots, you can see that all these patients that have been included in this trial were very chemo-refractory patients, and you saw that there is a complete response and 100% normalization of the peripheral blood numbers in the big majority of patients. But if you look into the same patients much less patients had a complete response of the lymph nodes. And that actually shows what I just pointed out earlier, is that since venetoclax only binds BCL2, those factors that are increased in the lymph node environment, other anti-apoptotic molecules like MCL1, BCLXL, and BFL1 are not hit by venetoclax. There is an advantage of giving this combination not only for progression-free and overall survival, but for treatment-free period. So it is, of course, a helpful thing. But the question is this then the ideal combination? So venetoclax works as single agent, ibrutinib works as single agent. Both should be given until relapse. If you combine venetoclax plus an antibody, it's a very powerful drug, but you see still that patient relapses, and specifically, you don't get complete normalization of the lymph nodes. So the question is, well, what if you combine then a drug that is very active in the blood, but not in the lymph nodes, with a drug that is very active by chasing out the cells of these protective niches in the lymph node environment? So then in theory, what happens if you give a BTK inhibitor, you chase those cells out of this protective microenvironment where they gain increased expression of these anti-apoptotic molecules beside BCL2 to the blood. You get this increase in lymphocytes in the blood, but those cells now only have BCL2, so should be very responsive to venetoclax single agents. Well, that is something that is very difficult to show in vitro, because you cannot really show this situation of homing and of adhesion. So what we did is we took a mouse model where you can inject leukemic splenocytes into wild-type mouse, and if you wait for a couple of weeks, those mice actually develop a CLL-like disease. And what we saw here is if you give ibrutinib monotherapy, the blue line here, you see first, very similar to the human disease, an increase in lymphocytes. Then it goes down again, and the mouse is under control, the disease, for a specific period of time, but then you get a relapse. If you give nothing, the red line, the mice will very quickly die within 5 weeks after the injection of the tumor cells. If you give a venetoclax single agent, it is active, but also the duration of time is pretty short. But if you give the combination of ibrutinib and venetoclax, that seem to be the most powerful with the longest remissions, as you can see here. So this is the white blood cells, that is the progression-free survival, which was the longest in the combination. And what you actually see if you look to the very large spleens of these mice is that the combination of ibrutinib and venetoclax results in the smallest spleen sizes, and spleen sizes in this model is a proxy for lymph node sizes in the human disease. Well, what is then the reason that we think there is synergy with these two drugs? What we know is that ibrutinib mainly acts by chasing the cells out of the lymph nodes. And we know that in the lymph nodes, or in this case in the spleen, that is the place where the cells proliferate. And indeed, if you look here, you can see that the ibrutinib is mostly responsible, single agent here, for inhibition of proliferation, while venetoclax is mostly responsible for activation of cell death. And if you combine this, so you have actually the best of both worlds in theory. But this data, among others, led to two pharma trials led by the company Janssen, where venetoclax and ibrutinib were combined. And it's the same schedule. One study was a phase 2 study that was performed in patients that were fit enough to otherwise would have get FCR. So this is a fit patient group, aged less than 70 years old, good performance status. Patient first got an ibrutinib lead-in for 3 cycles, which prevented very much tumor lysis problems. And then they got 12 cycles of the combination. And what was seen is that a CR, so complete normalization of lymph nodes and of marrow and of the blood, was seen in 55% of patients. Undetectable MRD in blood was seen at 77% and bone marrow in 60%. And well, the study is still too early to really call where we are, but at least what you could see here is that patients did very good, even patients that were also included that had a deletion 17p, for which we know who do very poor on chemotherapy. Another study that I was and I am heavily involved in is the GLOW study. This is a phase 3 trial is exactly the same treatment design, but then this was compared in elderly population against chlorambucil and obinutuzumab. So enrolled were patients that were older of age or young patients with a high SIR score, which is this very often used marker for fragility in patients, or low creatinine clearance. Well, in this group, CR rates were lower, but still 40%, and MRD rates were 55% and 52% in blood and marrow respectively. And what was important, and we just heard that it's now accepted in New England Journal of Medicine Evidence, which is this new sister journal of the New England. It's kind of the poor version of it, maybe. But what you can see here is that progression-free survival was pretty much almost a flat line for ibrutinib and venetoclax, while chlorambucil and obinutuzumab, you see this increase in progressions over time. What you do see, and I think it is important as clinicians to look at those data a bit more carefully, is that you see this very quick drop here. And what actually happened here was that a CT scan was performed. And of course, you can argue as clinicians that if patients have a progression based on a lymph node by a CT scan, is that something that is clinically relevant? Well, I think we have to wait for that. At least what we have seen already is that there is a difference in time to next treatment in the study, which I think is probably a clinically more meaningful way of looking at the data. What's also important is that although if you compare this to the venetoclax plus obinutuzumab studies or venetoclax and rituximab trials in relapsed patients, is that the number of patients that become MRD negative, and negative is the threshold now is 10 to the minus 4, so less than 1 leukemia cell in 10,000 normal cells, is that despite the fact that it was lower in IV, 55%, if you compare that to the German trial, what you do see is that after stopping, at least here, this is the first year after stopping, so 3 months versus 12 months after stopping, patients hardly changed from the group. So patients that were MRD negative, most of them stayed negative. Patients that were intermediate stayed intermediate, while we have seen with the other treatments, but specifically here, direct compared with chlorambucil, is that there is much more movement, that patients after stopping actually get higher grades of MRD over time. Another important study that kind of, I think, will lead the way for the coming years to fixed duration treatment is the Gaia CLL 13 study. This study was a study performed by the German study group together with us, the Hoven group from the Netherlands, Belgium, and the Nordic CLL study group. A very large trial, I think the largest trial in CLL, more than 900 patients were included. And patients were randomized between FCR or BR, depending on their age, so chemoimmunotherapy as standard arm, versus venetoclax rituximab, because there had been no data whether rituximab could be, well, maybe as good as obinutuzumab, as Gazyva. So the second arm was rituximab venetoclax fixed duration. Third was obinutuzumab venetoclax, same as the German trial. And the fourth arm was a triple combination with obinutuzumab venetoclax and also ibrutinib. And coming EHA, we hope to present you the progression-free survival data, which I cannot discuss now, but I can say here that the PFS data mirrors what we see for the MRD. So chemoimmunotherapy and venetoclax rituximab did give very reasonable MRD rates, but MRD rates were higher in the obinutuzumab venetoclax arm and even higher in the triple combination. And hopefully in a few weeks in Vienna, we can present also the differences in PFS data here. Another interesting thing, what is important to realize, is that which compartment now do you need to perform MRDs in studies at least? And what we have seen over the years is that if you compare bone marrow and blood for chemoimmunotherapy, there seems to be a larger difference than if you look to the also more active targeted agents. So you see here that 52% in the blood is MRD negative, while 37% is in the bone marrow. And you see that it always differs a bit, but it seems that it's a bit less different in the other arms. So conclusion on my first part of the talk is that venetoclax is an excellent backbone of fixed duration strategies. you have actually very successful partner drugs, anti-CD20 or BTK inhibitors. MRD, well, I didn't show you that here, but you've seen this data probably earlier, is that MRD is a very predictive marker for fixed duration venetoclax plus an anti-CD20 antibody. But whether MRD is also predictive for fixed duration venetoclax plus BTKI, or maybe more than the MRD itself, is the slope of the MRD over time, that remains to be determined in the next few years. So with the fact that we have now different options, chemo-free regimens in the first line, we are now exploring whether or not there are differences in those treatments, and that's the CLL-70 trial, where patients are randomized between ibrutinib monotherapy until relapse, or fixed duration of venetoclax and obinutuzumab, or a fixed duration of venetoclax and ibrutinib. And total 882 patients should be included, and now I think we're approximately at 500 something. So it depends a bit how you, where your point in life is. You can say, well, we have now these very good opportunities. We have chemotherapy, we have these novel agents. But you can also say, well, despite all these advantages, it's still a non-curative disease. And we know that whatever we do, we will get development of resistance. And as you can see here, if you look to long-term outcomes of the RESONATE study, this is patients in a relapse refractory setting, you see that patients with either ibrutinib or acalabrutinib, you don't get a plateau. Eventually, all patients will have progression, which by definition in this case will be refractory disease, because patients will take the drug until they have relapsed. Then, in fact, the question is there a difference in patients depending on their FISH, on their cytogenetic abnormalities? Well, that seems indeed to be the case, but you can see both for ibrutinib and acalabrutinib that patient with 13q seems to do very good, but at least in the relapse setting, patients with an 11q and specifically 70p seems to do worse, which was actually the same as chemotherapy, although data look much better than chemotherapy, but it's still the poorer arms. If you look to patients that are in the first-line treatment, it seems to be the case that p53 mutations or alterations, either 70p deletions or a mutation, seems to be less of a problem than in the relapse setting. And that I can show you here on the right. So you can see that if you give acalabrutinib or acalabrutinib plus obinutuzumab, despite the fact that those patients had a p53 dysfunction, there was not a clear evidence of poor function. So far, I think we can say that at least in the relapse setting, patients do worse when they have a 70p deletion on BTK inhibitors. But for the first line, it is less evidence. So why do patients get refractory and probably quicker if they have a 70p deletion? Is that you get specific mutations, and are already quite some described, in the exact BTK in the pockets where the drug will bind. And so most patients will get a single hit in a BTK mutation, and some patients will, on top of that, will get a gain of function mutation of PLC gamma, which is one signaling stage below a BTK. Patients, if you wait long enough, will develop this kind of mutations. And as I showed you already 2 slides earlier, the chances of getting these mutations is higher in patients with relapse disease than in the first-line setting. So if we turn back now to the relapse setting of venetoclax and antibodies, you can see that in first line, a very long-term good outcome is seen with venetoclax and obinutuzumab. And also very good outcomes are seen in the relapse setting, venetoclax plus rituximab, but you still see that the slope is downwards. Well, one of the questions is a bit, so which patient actually do have the highest risk of getting a relapse? Well, very nice studies were performed by the Australian group from Andrew Roberts, where he showed that the risk factors that seem to be independent of independently associated with durability, so which markers are relevant to look at. First of all, if they had bulky disease on start, those patients had an adverse outcome. patients that have been refractory prior to venetoclax to B-cell receptor inhibition. Favorable is if patient obtained this CR by 9 months and undetectable MRD by 24 months. And patient seems to do less well when they had a deletion 17p or p53 mutation, or patients with a notch mutation. And why do patients get resistant to venetoclax? Well, Blomberry showed at a cancer discovery paper in 2019, it was a late breaker on the ASH in 2018. You probably, some of you I think have been there also, is that if you treat patients long enough, patients will develop mutations in BCL2 itself, exactly in the BH3 binding spots where venetoclax is binding. And many of those have been described now, but it's for sure not the only reason. So we have seen that BCL2 mutations are seen only after very long term of treatment, late progression. We also have seen other BCL2 mutations, not only the famous one that was described here, but also other factors which are poorly understood are playing a role, like MCL1 induction, making the cells less sensitive to BCL2 inhibition alone. There is a link with metabolism, with OXPHOS, and there are some epigenetic factors maybe in play that increase the expression of other anti-apoptotic molecules also. So different than ibrutinib, that's kind of the message here. It is a multifactorial reasons why patients get resistant disease to venetoclax treatments. So that gives us, of course, a problem. So we now have not only chemotherapy, but we have all these targeted agents, but we can give, but we also know pretty sure that at one day those patients will relapse either after a drug holiday or during treatments. And the question is, what can you give then? And I shortly, in the next few slides, want to sum up what are the current data with venetoclax after BTK inhibitor, vice versa, but how active is a BTK inhibitor after venetoclax treatments? And thirdly, if you have given venetoclax for a fixed duration, by definition, you have stopped treatments with the promise that you can actually retreat patients with the same drug. And what is the evidence there? Can you actually retreat patients that come off venetoclax again with venetoclax? So first, the Venice-1 study. This was a study of patients that got venetoclax single agents for a 2-year period of time after previous other treatments, including B-cell receptor treatments. And if you look to the data, what you can see here is that patients that had B-cell receptor inhibitor naive, so BTK naive, versus other patients, you see that there is not a big difference, showing that venetoclax is very active, regardless the fact if you had a prior B-cell receptor inhibitor where you lost response to. Other way around, what happens if you start with venetoclax or had been treated with venetoclax and then have a relapse? How does that come out? And that's another piece of data that we obtained from this Mirana trial, from the fixed duration treatment with venetoclax rituximab versus bendamustine rituximab. And 1.5 years ago, 2 years ago, Rosemary Harrop presented this data in a poster. So quick reminder, this is the Mirana study, venetoclax rituximab versus bendamustine rituximab. And what I now want to focus on is, so what happens after relapse? So if you look to what patient actually received, I want to focus on the left part of the slide. So after they had been randomized in the study arm, venetoclax arm, how were those patient treatments? So partly they got again a venetoclax-based regimen. Also, it was a large number because there was a trial, a rollover trial, where patient could receive the same treatment again, venetoclax rituximab. Part of the patients were treated with a BTK inhibitor, part of it with chemoimmunotherapy, and a small piece of patients with other mostly study medications. So looking at in the venetoclax arm or in the chemotherapy arm that were retreated with a BTK inhibitor, what you can see is that most patients actually responded. Sorry, I make a mistake here. So this is a subsequent venetoclax treatment. So these patients got venetoclax, stopped treatment, and then again got venetoclax, and most of them were combined with rituximab again because part of this trial. And what you can see is that best overall response rate was pretty high, was 72% for the venetoclax rituximab treated patients, which was, well, pretty comparable, I would say, to patients that never had venetoclax before. If you look to patients that had a BTK inhibitor, you see also excellent responses and even very durable responses, 100% of responses in patients after venetoclax rituximab, and well, let's say 85% of responses in patients that never got venetoclax before. So conclusion so far is that targeted agents are highly effective, that smart combinations, and I think there are two very smart combinations, venetoclax plus an antibody, and from a biological perspective, maybe more interesting, venetoclax plus a BTK inhibitor. There are different characteristics of predictors for early relapse. There are different mechanisms for resistance, and the sequence order, as far as I now think, does not seem to matter that much. If you first start with a BTK inhibitor and then go with venetoclax or vice versa, doesn't seem to matter that much. So now we already know, you can predict the future a little bit, of course, is that in one way or the other, we will get patients that are refractory to both targeted agents, both BTK inhibitors and BCL2 inhibitors. And a very recent, a bit depressing study from Liu in Blood Advances showed the outcome of those patients. So either patient that first had the BTK inhibitor and then venetoclax, or then venetoclax and BTK inhibitor, doesn't really matter so much. You see very short overall survivals in these patients, which in this small study was only 3.6 months. So what do you do with those patients? Well, should you give chemotherapy, maybe for chemo-naive patients? Should you give other kinase inhibitors? Nowadays, we have non-covalent BTK inhibitors, which are active also in patients that have the BTK mutations. We kind of stopped giving PI3K inhibitors, although they were very active. We have seen this immunological side effects, but it's still an option. There are studies now with inhibitors downstream of the B-cell receptor, like MALT inhibitors. Some companies are experimenting now with inhibitors of other BCL2 family members, like MC1 and BCLXL. And of course, a very big thing in hematology, except for CLL currently, is autologous T-cell based strategies. And that is part that I focus a lot of in our group, in our lab here. So I want to pay the last few minutes of my talk about this part. Can we use autologous T-cell based strategies in patients with CLL? Well, I think the interesting thing is that if you look to the other diseases, I think you can say that targeted therapies, CLL is pretty much the winner of in lymphoproliferative diseases, which most affects, and nowadays also many options of chemo-free regimens here, which give very good long-term outcome. But we are kind of the losing parts if you compare us to the other B-cell malignancies, if you look to autologous T-cell therapy. And well, if you look to the data, checkpoint inhibitors in CLL, no response whatsoever. Bispecific antibodies, we are doing now the first phase 1 trial so far, not very clear data. And CAR T cells, there have been trials in CLL, and although responses are seen, this is less than 30% of the patients. One of the reasons is that if you culture T cells with CLL cells, then what will happen is you get a lot of T cell dysfunctional features. A long time ago, the group of John Grimman described defective immune synapse formation, increased expression of inhibitory molecules. We could show impaired proliferative capacity, dysfunctional cytolytic ability, and latest we could show altered T cell metabolic plasticity. And as a result, although you can, with either a CAR T cell or a bispecific antibody, you can make a T cell recognize the cancer cell. If it is a weakened cell, a dysfunctional cell, it doesn't do so much. So the question is a bit, can we overcome this? And one of the things that we are experimenting now with is, can you take out CLL cell out of the equation? Because in theory, if we say that a CLL cell actually causes this T cell dysfunction, what would happen if you take the T cells out, the CLL cells out? And this was something highly hypothetical in the time of chemotherapy, because either an alkylator or a purine analog not only kills your CLL cells, but also part of your T cells. It is possible now with a drug like venetoclax, and probably also by ibrutinib. So that is one of the things that we have shown. I don't show you because of time the data here, but actually what we indeed could show is that if you treat patients over time with venetoclax, you see an improve in T cell function, but also an improvement in the phenotype. So if you gate out your CD8 cells, for instance, you see much lower levels of PD-1 on those cells. Another option is we know that T cells do poorly respond, but perhaps they do respond on bispecific antibodies. One of the reasons that we hypothesized that it could be the case is because we know that these T cells have a problem in forming proper synapses, and therefore activation is lower. But since a bispecific antibody forms an artificial synapse, we thought, well, maybe this could improve it. So a DART is a specific a bispecific antibody that we used. So I show you the data of the DART later, but if you still first look of normal T cell activation, so you take T cells of healthy controls, here CD4s and here CD8s or CLL cells, you activate them with CD3, CD28, you see that cells do get activated if you look to CD25, but always this is much lower in the condition of CLL than of healthy controls. But now if you don't give soluble CD3, CD28, but you give a CD3, CD19 bispecific antibody, it seems that this dysfunction can be overcome by a bispecific antibody. And this is true for activation, as you can see here, but we had the same data for proliferation. So again, poor proliferation in CLL T cells if you give the normal stimulus, both CD4 and CD8s, but it's normalized by this bispecific T cell engager. And the same is true for degranulation, lower in CLL, but not lower anymore if you treat cells with a bispecific T cell engager.
For school.
Sorry, is there a question?
Ma?
Oh, no, I don't think so. So I continue.
I think somebody is unmuted. I'll just quickly find them and mute
Yeah, I
them.
found it. Yeah, Elizabeth Botzile, but I think she's muted now.
Yeah, okay, thanks.
Okay, good. So a bispecific antibody seems to work. The question is a bit, how does it work? And is it apoptosis or is it another mechanism of cell death? Well, to make a long story short, what we could show if we take a B cell line and we make them apoptosis resistant by a Buck knockout, those cells are completely resistant to venetoclax, but are still sensitive to this bispecific T cell engager. And also, if you treat the cells with QVD, which is a pan-caspase inhibitor, you see that those cells are completely venetoclax resistant because that's purely apoptosis. But for the T cell engager, the cells are still sensitive. So what actually we think is that bispecific T cell engagers kill CLL cells by T cells in a non-apoptotic fashion. So to summarize a bit, the T cell phenotype and function can be restored, as I told you, after depletion of venetoclax. Autologous T cells efficiently kill CLL cells through bispecific T cell engagers. T cell mediated cell death at least is partly non-apoptotic. And what I didn't show you here, but we have published is that venetoclax resistant CLL cells remain sensitive to T cell mediated killing, probably because it's a non-apoptotic cell death. So we think there is a future of bispecific antibodies. We have shown you this for CD3, CD19 antibodies, but we also published on bispecific antibodies that activate NK cells towards CLL. We have shown this also for gamma delta T cells, and we also have a trial on a gamma delta T cell CLL bispecific engager. And my latest slide is our new Hoven study, which we will do together with the German group and the Nordic group, where we actually will combine these two ideas. So we started the patient with venetoclax to debulk the patients to improve T cell function, and then we start with a bispecific antibody, in this case epcoritamab, which is a CD3, CD20 antibody, to see whether or not we can induce long-term remissions. We will compare two different treatment schedules, either a 2 years of both drugs or 2 years of venetoclax and only 6 months of epcoritamab, which hopefully will give a better toxicity profile. And then we will compare this to the Murano schedule to see if that gives an improved outcome. And this is my last slide. This is my study group here helping us with the lab studies. I collaborate on the T-cell part with the group of UPenn, Jos Melenhorst. The CD3, CD19 studies were done together with Janssen Pharmaceuticals. And part of the studies we do together with the group of Rajeka from Felix Wensveen. And that was my talk, so I will stop sharing and then we can have some discussions.
Prof Kater, thank you so much. That is really a wonderful overview, and I think especially very interesting about the pathophysiology and the mechanisms of actions and how these drugs work together. While any of the other people in the room add their comments or questions to the chat, maybe a few questions from my side. So can you perhaps just comment on, I've got a sort of a couple of questions that relates to the lymphopenia that these patients develop, especially if one would give continuous treatment. Do you ever see that the lymphocytes recover, the normal lymphocytes and the hypogammaglobulinemia, if you do not discontinue your combination? And then together with that, are you using any prophylactic antibiotics? And if yes, what do you use? Antifungals, PJP, varicella zoster? Maybe if you can start with that.
Yeah. Thank you for that question. So actually, it doesn't. What I can do, and that's also of interest. Meanwhile, I will look up the data on that we have on the COVID vaccination. That could be relevant. Let me quickly see if I can find it. Yeah, I got some of it here. Okay. So actually, if you only give targeted agents without chemotherapy, and ibrutinib or venetoclax, in studies we gave patients cotrimoxazole and valacyclovir, but actually that doesn't seem to be very needed. You don't affect your CD4 numbers, so PCP prophylaxis is not that needed, I think, and the same is true for herpes prophylaxis. Most of your patients will have low IgGs and remain having low IgGs, although for ibrutinib, it has been shown that actually over time your IgA level seems to increase, and that might actually be a bit protective. But I think related to your question, I want to share with you the data that we got on. Yeah, am I showing my screen now?
Yes, you are.
Okay. So it's in Dutch, sorry, but it was from an internal group. But I think it's important to show you what we did. Is we gave the COVID vaccination, the RNA vaccine, to patients with CLL, not that great numbers, but 56 patients got it while on watch and wait. 38 patients got ibrutinib, of whom partly half of those patients were in our trial where we combined ibrutinib and venetoclax. And we had long debates here in the Netherlands is how do you define your cutoff? So this is the antibody response. And well, it was argued that if you are above this number here of 300, those patients seem to be protected based on a large study in normal individuals or healthy individuals. And if you are below the 300, if you're below 100, those patients had no response at all. And what we could see is that after 2 shots, 70% of patients during watch and wait had normal immune responses of neutralizing antibodies, but this was much, much lower in patients that received ibrutinib. Only 28% of those patients had adequate numbers. And actually, the same numbers have been obtained by the Israeli group, showing the same for venetoclax. So I think to address your question, normal prophylaxis is not that needed, I think, but you do for certain have a problem with COVID and with vaccination responses.
Thank you very much. We've got some questions in the chat box. So Nomusa Mashigo asks, I note in one of the slides the effect of TP53 aberrancy and notch mutation on the response to venetoclax. Does IGVH mutation status have the same effect? Or is the response the same for mutated versus unmutated CLL to venetoclax?
Oh, no, that's very good. I should have mentioned that. Is it something, if I may ask a question back first, to Nomusa or to you, Vernon? Do you routinely measure IGVH mutation status?
Not routinely in public sector because of cost. In private sector, it is often measured, but maybe some others can comment as well, because we've got quite a variable practice around the country. But in our setting, we can't do it routinely because of cost in the public side.
Okay. Maybe Dr. Mashigo, because you asked a question, do you do it routinely or not? No, okay, thank you. No, actually, I should have mentioned it. Sorry for that. The interesting thing, what happens, but what we see in all the trials so far is that what I discussed with you is that all those targeted agents always outperform chemotherapy. But if you distinguish the group between unmutated and mutated, there is a very, very big difference. In unmutated cases, there is a very big difference between PFS in targeted versus non-targeted agents. But in the mutated patients, those lines are mostly overlapping. And well, if you promise that you didn't hear it from me, indeed, that's also what we see in this CLL 13 trial, where we see that chemoimmunotherapy is less well also for PFS for the venetoclax combinations, but that's mostly in unmutated patients. And in mutated patients, those lines are really much closer to each other. And that gives a important debate, specifically here in the Netherlands also, where many doctors and also our guidelines state that after a long period that we didn't do anything with mutation status analysis, that you should measure the mutation status, because patients with an unmutated disease for sure have a much shorter PFS on chemoimmunotherapy, while patients with mutated disease, well, I think there is still a good argument also for cost, if you consider about costs, to give patients still chemoimmunotherapy and wait with your targeted agent for a second or third line treatment. So yeah, that's a very good question, Musa, and that's indeed the case that there is a big difference in those groups.
Thanks, Prof. Then there's a question from Dr. Moses Chatambutsa. He's in Harare in Zimbabwe. He says, thank you for an interesting presentation. Which CLL patients would you target MRD negativity in your clinical setting? And secondly, do you have any real-world data for patients using ibrutinib intermittently for disease control? And do they differ significantly in terms of time to next treatment, rate of disease transformation, or overall survival?
Yeah, thank you for that question. So to be honest, I think it's still too early to do MRD testing outside a clinical trial. Because what we do know is that indeed patients that become MRD negative or undetectable MRD after treatment do better than patients that are still positive, specifically for the venetoclax combinations, venetoclax rituximab or venetoclax obinutuzumab. But the data don't support so much that you should have treated those patients differently if by for its continuous treatment. If you look to one of our papers on the Murano study, venetoclax rituximab, is patients with a positive MRD at the end of the 24 months of treatment. Almost all of those patients had already a rising MRD before that, showing that those patients had some kind of resistance built up by venetoclax. And well, we didn't test it, but I would assume that if you would have continued venetoclax in those patients, MRD was already on the rise, and it wouldn't help you so much. So I think as long as we don't have trials supporting that you should treat patients differently in an MRD negative or MRD positive way, I think it's too early to do it. I have to say that we are now debating with one of the pharmaceutical companies a trial where pretty similar to Hodgkin trials in using PET-CT, is that after a very short, maybe 6 cycles of treatments, we will do an MRD testing and see if we can stop patients that are MRD negative and maybe switch treatment that are MRD positive. And indeed, looking to the Hodgkin trials where you do the same thing, right? Either you intensify if you're still PET positive after 2 cycles of ABVD, for instance, or you can actually lower your treatment cycle. So that's maybe how we will use MRD in the future. Having said that, that's the official answer. My personal answer is I do use MRD in one group of patients, but it's completely outside trials. It's more a gut feeling that I think I can do that. Is I get now more and more patients that have had chemotherapy at first line, then got venetoclax something at second line, and then or no, because BTK was earlier approved than venetoclax, so most patients have had a BTK inhibitor as second line, and then come to me for treatment with venetoclax after relapse. And those patients, specifically younger and fit patients, I feel a bit uncertain whether or not I should give them 24 months of venetoclax, or I want to induce a disease control and then quickly go to an allotransplant, because that's still effective in patients. And there in that group, I do use MRD, and at time point of 9 cycles, 3 months after stopping of rituximab, I do test MRD, because what I know from the Mirana trial is patients that are MRD positive at that time, specifically when they have a 17p deletion, hardly any of those patients will stay remission free for the next year to come. So those patients I actually try to lead to an allo if possible, but patients that are MRD negative, I feel secure enough to actually wait with an allo, finish treatment with venetoclax, and just follow this disease over time.
Right, thank you. From my side,
sorry, you had also this second question.
Oh yes, patients are using it intermittently.
Yeah, so that never an official trial have actually used or looked into that, but from the large trial and a very rich data set of real world data, many patients actually had stopped ibrutinib because of side effects. And if patient had disease control, the progression-free survival is approximately 2 years after stopping. So indeed, and it very much depends also on the disease control. If you do it early, when there is still a lot of disease around, relapses are much faster and patients feel horrible. But if there is actually a good disease control, those patients seem to do pretty well. I don't think you should do this in your own practice, because we don't have any data, but at least we know that if you need to stop a patient because of side effects, then I would just wait till relapse occurs and then start a new treatment, as long as there is disease control, and don't start too early.
We've got a question here from Dr. Shalene Parasnath. She's the head of hematology in KwaZulu-Natal at Albert Luthuli, Inkosi Albert Luthuli Hospital. What conditioning protocol you use in your center for allogeneic transplant in CLL?
Yeah. So even before that, if Charlene, I make it a little bit broader, the question. What do you do if you don't have any options anymore anyway? But we know from the old allo trials, and of course, maybe after 2000, but for the last 20 years, there has not been a prospective allo trial because of all the new agents. But what we do know from retrospective analysis, specifically from Johannes Schädelig from Germany, who did a very good job there, is that if you have lymph nodes more than 3 and specifically more than 5 centimeters, or have leukocytes above 25 at the moment of transplant, then there is hardly a chance that you get a plateau, and most patients will relapse within the first year. So you have this paradigm that you need patients that are chemo refractory, and maybe in this case also targeted agent refractory. You should get them into some kind of disease control before you actually start your conditioning. And one of the things that we do in our center, which is highly toxic, of course, but active, is a platinum-based treatment, for instance, DHAP. And one of the reasons, that was an old study actually of our group, what we could show is that cisplatin works also on patients with a p53 mutation and also induces apoptosis. So DHAP 3 cycles is a highly toxic, of course, as you know, but also highly effective study regime if you don't have other options. And then the condition is actually the standard regimen, so flu TBI for patients that you want to give an non-myeloablative transplants. And since fludarabine has always been the choice, also because fludarabine has this classical CLL effect as well.
I want to follow up on that question about fludarabine. Have you seen a difference in responses to patients, fludarabine refractory or not? Because traditionally they're quite difficult patient groups to treat. So if a patient has had FCR or similar prior to one of these novel agents, do you see a difference in response?
After FCR, you mean?
Yes. So in terms
well,
of your venetoclax and ibrutinib.
Yeah, so I have to say, if you look to the Murano trial, the big majority of those patients, there was, so when we started the Murano trial, there was, well, I think only one country was ibrutinib allowed. So 99% of patients in Murano were chemo experienced as first line treatment. And of those, approximately 40% had FCR, 50%. So what we have learned, and also from the Resonate trial with ibrutinib, is that there is very good response to those agents. Having said so, I also showed in one of in an ASH 2 years ago that patients that have a complex karyotype, defined as 3 or actually better, maybe 5 aberrations, do more poorly. What we also know is that patients with a 17p deletion do more poorly. So with that knowledge, we know that the chances that patient will obtain a complex karyotype and or p53 alterations is probably much higher after more intensive chemotherapy. So there is no direct effect. I think patients that have had FCR and have a mutated B-cell receptor, have no 17p and have a non-complex genotype, probably have a very good response. Patients after FC, but it is also true that patients after these kinds of chemotherapies have just a higher chance to get this high risk CLL as a selection way, and those patients do more poorly. So there is a link, but it's more because of the FCR related induction of poor risk markers that there is a direct effect of fludarabine and novel agents.
Moving forward, do you think allogeneic CAR T cells will be more important than autologous, noting the problems with T cell function in autologous CAR Ts?
I hope actually. Yeah, so what I hope is that we actually find ways to improve autologous CAR T cells than allogeneic. Because what's also true is, I think it's not really depending on whether it's autologous or allogeneic T cells. The problem is that as long as there are CLL cells around, they will actively give this T cell dysfunction.
Okay.
And that's exactly, I think, why Johannes Schädeli earlier found indeed that as long as there is disease activity, your allotransplant also doesn't work, because you get again a T cell dysfunction. So I would more invest in autologous T cells, and what we're trying in our lab is to build in resistance mechanisms on the T cells to be better resistant to those CLL-mediated T cell dysfunction, but we don't have that answer yet. But I think if we can do that, I would prefer autologous T cells, because so far I don't think that allogeneic is that much better in this setting.
Okay. Wonderful. I believe you actually had to leave us already, and that we don't want to keep you unnecessarily long. Professor Kater, thank you for a wonderful presentation. And really for very insightful answers to the questions asked. It's wonderful to see someone with such passion and
and I think I will see some of you in Dubai in a few weeks now, right?
Fantastic. Yes, we will.
Yeah, very nice.
Just to the rest of the group, the link has been posted for CPD points. You can just click on it, take note of the meeting code for today, which you can see there is 26. You have to just type that in with your MP numbers, etc., and that will be sorted. Thanks again to everyone who joined today. It's a bit of a shorter day than usual. Thanks again very much to Janssen, who supported Prof Kater to give this talk to us. And Prof Kater, we hope we can see more of you in the future.
Yeah, maybe also when there are any specific questions, you can maybe through you, Vernon. That's maybe the easiest, but you can also always address specific questions, and we can have a normal chat around.
Well,
about
that
it.
is really fantastic. It's nice to,
All right.
we often have difficult patient cases, and it would be great if
Exactly.
we can
Yeah.
ask advice. Wonderful.
Yeah, I think
Thank
you
you.
have my email address, right, Vernon? So you can.
Yes, yes.
Okay, perfect. All right.
Thank
Thank
you.
you very much.
Okay,
Bye-bye.
have a lovely day, and
Bye.
bye-bye, everybody.